So we are going to go ahead and get started. I want to thank you all for joining us for Women's Heart Health 101. And I'm pleased to welcome two extraordinary women that we are lucky to have here with us today. This webinar is brought to you by Burner Law Group, which is a boutique law firm with offices in Manhattan, East Setauket, and West Hampton Beach. The Burner Law attorneys concentrate in the areas of estate planning, trust and estate administration and litigation, guardianship, and elder law. Britt Burner is going to serve as our moderator today for our discussion on women's health. So let me tell you a little bit about her. She's an extraordinary woman and is the driving force behind Burner's Law's Manhattan office, serving clients from New York City to the East End. Britt has been named a Super Lawyers Rising Star, a Schneps Media Brooklyn Star Under 40 event, an Outstanding Woman in Law by Hofstra University School of Law, and a Caregiver Champion by Caring Kind. Britt serves as treasurer of the Elder Law and Special Needs Planning section of the New York State Bar Association. Britt also serves as a charter member of the Advisory Council of the Katz Institute for Women's Health at Northwell. Welcome, Britt.
Thank you. I'm so happy to be here.
Thrilled. So Britt is going to be interviewing the outstanding Dr. Stacey E. Rosen, who's a senior vice president of women's health at the Katz Institute for Women's Health, which is a division of Northwell Health. Dr. Rosen is also the Partners Council Professor of Women's Health and Professor of Cardiology at the Zucker School of Medicine at Hofstra Northwell. Dr. Stacey Rosen is one of the leading experts in the field of cardiovascular disease and women's health. In her role as a senior vice president for Katz Institute for Women's Health, she oversees the development and coordination of a comprehensive and integrated approach to women's health services at Northwell Health. In this role, her mission has been to focus primarily on the elimination of healthcare disparities through comprehensive clinical programs, gender-based research, community partnerships, and education. She's been a practicing cardiologist for over 30 years. Stacey has recently co-authored the book, Heart Smart for Women, 6 Steps in 6 Weeks to Heart Healthy Living. You should pick that up. And has co-produced her first documentary titled Misdiagnosed, which premiered at the SynQuest Film Festival on March 7th, 2020. Thrilled to have you here. We're so lucky. Welcome, Dr. Rosen.
Thanks, Elizabeth. It's wonderful to be here with all of you.
Terrific. So it is my honor to turn the floor over to these incredible women for an important discussion on women's heart health. As I mentioned earlier, please feel free to ask questions during the conversation via chat and Q&A, and we will get to them, as many of them as possible, after the conversation. Britt, please let me turn it over to you.
Great. Thank you so much, Elizabeth, and thank you to Schneps Media. I'm so glad to see that so many people are here today and engaged in this conversation, writing in the chat, and we're excited to bring this topic to you. The star of the show here is Dr. Rosen, and I'm just here to help her along as we bring this important information to you. I got involved with the Katz Institute a little over a year ago. I first met Dr. Rosen and everybody else, and it's really been eye-opening for me to see the differences in how women should be treated from men in the medical field and what Katz is doing to get us there. And so we're going to bring you a little bit of that today. On top of that, we're wearing red today. As you see, I've got my Go Red dress on my pin. We go red in February for heart health and for women's heart health specifically. And that's really what we're going to talk about today. And I'm so excited. So Dr. Rosen, let's just get started. Can you start with telling us a little bit about Northwell and the Katz Institute?
No, absolutely. Let me first start by thanking you, Britt, and the Burner Law Firm for partnering with us both at Northwell and Katz, but also in the community, because that's where all the magic happens, honestly. And as well to the Schneps Media Company to allow me to be here, because this is the best part of my job, to be able to meet even virtually with like-minded thinkers and share some information. I've been a practicing cardiologist at Northwell Health for 26 years now. It's only the second formal job I've had in my career. And it's been interesting. I grew up on Long Island on the South Shore, and watching Northwell grow from smallish, well-respected local hospitals to really the powerhouse in education and research and clinical care that it's become. We are the largest healthcare system in New York State. We're also the largest private employer in New York State. We have about 76,000 employees, and our clinical programs, hospitals, ambulatory, regular doctor's offices, emergency care, run the gamut from up into northern Westchester, throughout the 5 boroughs, and all the way out to both forks of Suffolk County. We opened the first new medical school in New York State in over 45 years at Hofstra University in partnership, and in a very few years, we've graduated, I think, 7 classes. We have risen in credibility, national reputation, in grants, and where our students go, almost as if we were a 100-year-old medical school. We've got an extraordinary dean. We're also home to the Feinstein Institutes for Research, where hundreds of millions of dollars in NIH support grow each year to really answer the serious questions that our communities share. We see 5 million women a year, and it's been a very special place. Our executive director, our chief executive officer, Michael Dowling, is innovative and an extraordinary force on Long Island. So the Katz Institute of Women was the brainchild of Iris and Saul Katz. And the story goes that Iris went to the doctor. They both see internists. They are a lovely 60-year-long married couple in their 80s. And when information about men taking aspirin to prevent heart attack came out, their internist told Mr. Katz to start taking an aspirin. And Mrs. Katz looked at their shared internist and said, well, what about me? And the wonderful internist says, we don't really know about you, Iris, because we don't include women. So the Katz Institute for Women's Health was born out of the concern that historically, we always assumed in science and medicine that men and women were the same, and that it would be easier to study men because those pesky hormones got in the way for women. And we joked that the only difference was the parts of the body covered by a bikini. So some of us have actually called this bikini medicine. And Katz realized that we did a disservice for hundreds of years to women. We didn't include them in research. We poo-pooed their symptoms. Oh dear, it's just in your head. And that approach led to terrible outcomes for women. So the Katz Institute really sees women's health differently. We look at women knowing that they're not little men with hormones. We partner with our communities, and that's what our Institute's about. So, we always used to think that women's health was just the bikini, our reproductive organs and breasts mostly for women. But the truth is, women's health has a different definition than that. So yes, there are the conditions that are predominant or unique to women, pregnancy, gynecology, but then there are conditions where women are affected more than men. Things like lupus and osteoporosis, gallstone disease. And we don't even know why that some of those conditions, 80% of the people who have them are women. We can't just say that that's an okay fact. That's something that we need to understand better. And then finally, there are conditions where the manifestations, the way the disease presents itself, are different. And heart disease is the classic case, because when we thought men and women were the same, we even thought heart disease only happened to men. And then I learned that lung disease is different, and liver disease are different, and intestinal disease are different, and bone health is different, because every organ in your body is either a male or a female, and every part of our body needs to be looked at through a gender-based approach.
This right here is exactly why when I started hearing about the Katz Institute, I wanted to get involved, because I've got a lot of sisters, and not to mention women that I know, our law firm full of women, and nobody knew about any of this, and I didn't hear about any of it. I think one of the things I love learning about are the pillars of the Katz Institute. So if you could tell us a little bit about those, I think it really shows how far-reaching it has to be.
No, thank you. You know, when we think about the totality of how women stay well, and not for nothing, there's been research that shows that 80% of a family's decisions about health are made by the women. You know, we know that women run the world, but we also know that women's needs were underappreciated for long. So at Northwell and at Katz, we also know if we do right by our women, that we will do right by our families and communities. And we know, how to manage that. So our pillars, as Britt referred to, are the focuses of our work. So the first is clinical programs, because we know, and we'll talk about in the heart world, that if one size fit all, it's all the same, that we don't appreciate the differences. And if there are any men on the phone or women who have men in their lives, when we do this badly, it actually impacts on men's health as well. If we overstudy men and make assumptions about men, we don't do right by them either. So our first program first pillar is clinical programming. So in the Katz Institute, we have special sports medicine doctors for women. We have special heart doctors for women. And we also know that in each of these programs, we can't do our healthcare siloed. So that we know in the women's heart program, for instance, we have a therapist, a behavioral health professional, we have a nutritionist, we have an exercise physiologist, and we make it easy for women for these programs to be that way. I'm going to skip to research because as a colleague of mine from Massachusetts says, if you don't ask the question, you don't get the answer. So in every part of what we study, we ask the question, is that the same for women? Is that different if a man is 40 versus a woman who is 60? Then we turn to community partnerships. We know that only 20% of your ability to stay healthy happens in your doctor's office or an emergency room. And 80% of your ability to stay healthy happens in your communities. So why would any of us rebuild the wheel, right? What we'd love to do is identify partners, whether it's Britt's group, whether it's this wonderful media company that we're here with, whether it's a collaborative of retired women in a community, because we know when we work with groups that we can amplify each other's message. And finally, education, which is why we're here today. The old days of a doctor sitting and saying, this is what you have to do, and it was usually an old doctor scaring all of us, that's over. Each of us needs to be, an active partner in our care, and you do that better when you're an educated consumer.
Thank you. And I know this is a slide you guys have shown me before, and I think this really just goes to the heart of it.
Yeah, so I have to, remind people, and I apologize if sometimes I sound exasperated, but women's health is not about women doctors, though I'll tell you privately, I think we do it better, but it's not about women doctors. It's not about the red dress pins that, Britt and I are wearing. What it is that it is the science and the healthcare that led to women, to disparities in outcome in women. Did you know that the truth is that they only use male mice in laboratories until about 15 years ago. And I understand from my research friends is that female mice were more expensive. I mean, we can make jokes about it, but they were more expensive because the menstrual period really did change data, perhaps, but women get menstrual periods. So you can't sort of make believe that you just ignore that. You have to study it. They only use male cells. If they were studying cells on, little microscope plates, it was just easier to get rid of the pesky hormones. But this is what women's health is. The importance of having a gender and sex-based look at everything.
Great. In February, we wear red and we wear our pins and we shine the light on heart health and on women's heart health. And you were kind enough to come out to West Hampton last week, and our building is lit up red, and it will be for the rest of the month. So tell us a little bit about why it's so important to focus this month on heart health.
No, thank you. This is something. So I graduated medical school in 1985, and that is the year that the death rates for men versus death rates for women from heart disease crossed. So for the first time in 1985, more women died of heart disease than men. Yet when I went to medical school, I was taught that this is a man's disease. And for the next, from 1985 to almost 2008 or so, more and more women were dying of heart disease and fewer men. There were all these exciting advances: aspirin, clot busters, stents, open heart surgery, amazing new medicines, but they were only helping the men. We weren't giving them to the women, and we weren't testing them. And by 2004 or so, the largest gap between the number of women who died of heart disease from men in a disease that we thought was only a male disease. And it wasn't until we started advocating for ourselves, demanding that the right tests be done, demanding that our symptoms be taken seriously, coupling that with research to specifically see, hey, what was the deal here, that women were doing so much worse than men, despite all of these amazing new discoveries. So know that heart disease of all forms is still the #1 cause of death in the United States for women. And I live on Long Island, and we are all worried about cancer and breast cancer. And I never, minimize the need to get mammograms and the importance of, evaluation for breast cancer. But more women die from heart disease than all forms of cancer combined. The good news is that 80% of heart disease is preventable. So if I start with the bad news of this being the most serious condition that each of us is likely to be stuck with, I can tell you that this is preventable, and the prevention starts early. 90% of us, including me, have at least one risk factor for heart disease, so it's almost all of us, but we can make simple and consistent changes. But we still know that when it comes to women, once we get heart disease, we don't do as well. We are more likely to die the first year after a heart attack. We don't do so well with heart failure compared to men, or bypass, or stenting. So that speaks to, even more importantly, why we want to be sure to prevent this starting as young as we can.
Great. And can you speak to the differences between men and women?
Absolutely. And so the differences are in every aspect of it. So, I think going back, we used to think that this wasn't a disease of women because on average, women got the disease 10 years later than men. And we do know that estrogen, the stuff that goes up and down during our menstruating years, is something of a protector. So we used to think that women only got it when they were old. But the truth is, we found that that wasn't the case. Many of you may remember years ago, there was some research. Well, what if we just give women estrogen? Can we stop all of the heart disease that they get late 50s to older? And we found that that wasn't necessarily the best way to think of it. So there are some traditional risk factors, but even those, high blood pressure, diabetes, they're more potent, meaning they're more dangerous. So a woman diabetic is 3 to 7 times more likely to get heart disease and die from it than a male diabetic. The same thing is true for Black women with high blood pressure. So even some of the usual, heart risk factors, stroke risk factors, are what we call more potent in women. Women tend to be less active than men. Women, unfortunately, in the United States tend to be more obese. And then finally, which is really cool and a real passion of mine, Britt, is things that are unique to women, stuff that we don't see in the men. And the most interesting one to me are things related to, back to the bikini approach, things about our pregnancies, when we get our first period, when we get our last period, and all kinds of things related to our gynecologic health that now we've discovered has an equal sign with our heart health. We joke that the heart is a lady part now, so.
Can you talk about the symptoms? So when a woman is experiencing an episode, how it might manifest differently?
Yeah, that's really important. And that's another thing that led to all the bad outcomes we saw in the 90s and the first, 10 years of this century. So we didn't think women got the disease, so we didn't treat them. And then we discovered that there was something, you've all seen it. They call it the Hollywood heart attack. It's a man, he clutches his chest. I have an elephant sitting on my chest. And, the ambulance comes and everyone in the emergency room is frantic. Well, a woman may get something different. We sometimes do present with chest heaviness, but we can sometimes present with just some intestinal or GI upset. I'm nauseous. I feel like I'm going to vomit. The food doesn't taste good. We could have back pain in our upper shoulders or our lower back. I've had patients who tell me they just had this bad feeling like something wasn't right. There can be fainting spells, fatigue, and not for nothing. If many of you are managing all the things that women manage, these symptoms are pretty generalized, and it may not lead you to think it's heart disease. So imagine we've told you that women don't get heart disease, that heart disease equals chest pain, and you're getting this kind of stuff. And then you go to an emergency room and nobody there thinks you could be having a heart attack. So they put you in the back. And women also have a tendency to be very quiet. Oh, I don't want to bother anyone. I'll sit here, you go first. And the truth is that also led us to do wrong by women when it came to heart disease. One final really funny, not funny, but disheartening statistic is that if a woman was presented with symptoms that sounded like a heart attack, she would call 911 if those symptoms were happening to the person next to her 92% of the time. If those symptoms were happening to her, only 60% of the time would she call an ambulance. So we need to advocate and know these things.
Right. I don't want to be a bother. I don't want to complain. I don't want to be a burden on anybody else. Yep, we all have that. It's true.
Absolutely.
And let's just go into what some of the risk factors are, because we're going to get into after that, detecting these issues and preventing these issues. What are the risk factors where you should really be keyed into this?
No, absolutely. Thank you very much. And know that a heart disease, which is, the junky material that grows into our blood vessel, that starts as young as in your 20s. And we interestingly know that from a study that was done on men who died during World War I. And we looked at their arteries in autopsy studies, and we found that even in these young, healthy men, there was the beginning of plaque in the arteries. So these risk factors are things that you don't ever want to say, well, when I'm 40, I'm 50, I'm 60, I'll worry about them. So cigarette smoking is still the #1 preventable thing we can do. And in some age groups, women are smoking more than they used to. Vaping and e-cigarettes is as bad, for some things actually even worse. Poor nutrition and poor diet. Our nutrition choices, I try to avoid the word diet because it makes women squirmy. It's just the food choices. And that's another thing that with a little bit of education, we can make the right choices. Physical inactivity, you notice we don't use the word exercise because I think that's a curse word too. And choosing to move is critical. Obesity, and there are numbers. BMI, body mass index, is a little chart you could find online. You put in your height and your weight, and you could see what your BMI is. And they also speak about where we have our weight. So you could picture the difference between an apple and a pear. If you're an apple where your weight is around your waist, that's more concerning for heart disease. If there's a family history, and by family history, we mean somebody in a male relative who had heart disease before 55 and a woman who had heart disease before 65. High blood pressure, which is particularly deadly because it doesn't hurt. And everybody doesn't feel high blood pressure for years before they can have a catastrophe. That's the second most preventable cause of heart disease. Abnormal cholesterol is an important thing, and the numbers that are acceptable and not acceptable have been moving. There's a test called a coronary artery calcium score, which we think can be helpful. The metabolic symptom is a combination of diabetes and other pre-diabetes and other forms of cholesterol abnormalities. And for women, those ones with the stars, gestational diabetes, pregnancy-related hypertension, to small babies, repeated pregnancy losses are all things that matter, as well as immune diseases like lupus, rheumatoid arthritis, which do something to women's blood vessels that can also put them at risk. The only other thing, Britt, that's not here that I think we're learning a lot more about is stress. Women who suffer from anxiety and depression, even mildly, are at higher risk for heart disease. And we know that connection is real, and there are things that we should do to manage it.
Right. So let's get into a little bit about screening and what we can do. I think, well, you know, between me, you, and the many people on this webinar, but after I even found out we were doing this webinar, I went to the doctor, and I have some genetic, some genetics that are not in my favor, and I found out that I have high blood pressure, and I have high, bad cholesterol. And that was shocking to me, even with that genetic background, because I work out and I eat well, and I eat what I'm supposed to eat, and I do all the things I'm supposed to do. So how can we find out if we are in this category, and what should we be doing when we're younger to make sure that we're watching these things?
No, that is such a great question, and thank you for bringing up the concern that, oh, I'm thin, I run, I'm young, I can't have these things, because that also played into bad outcomes in the past. It can't be. So the most important thing about how we sort of like get on the journey, even in our teens and 20s, to heart health are a couple of things. First, you want to know about your family history. And sometimes that means sitting down with parents or grandparents and finding out, really what kind of illnesses they had, when they developed them, because how much primary prevention you'll do depends on that. Then you want to know about your own risks. So that means in your 20s, having an evaluation. For women, it could be with their gynecologist or family medicine doctor, adolescent doctor for young adults, or their internist. You want to know what your blood pressure is. You want the blood test to check your blood sugar for diabetes or pre-diabetes. You want to check a cholesterol panel. You want to check your height and weight, and even to put a tape measure around your waist to see what your waist circumference is. Then for some people, there are other tests. Some people get a physical exam to hear a murmur, to hear anything like that. And so when we talk about heart screening, it's not always the big fancy and expensive tests, but sometimes it's just the simple, history, physical, blood tests, and usually an electrocardiogram. And then depending on your risk profile, the frequency that you see a doctor, the frequency that you have things checked, the need for treatment, sometimes medicine, sometimes not medicines. We have non-medication ways to treat all of these risks, will determine your individualized way to be screened over a lifetime.
Yeah, I think one of the things, I'm a person, I was always good. I got my physical every year, and the blood pressure thing was always what surprised me. Every time I go to the doctor, they say, well, you have high blood pressure, but it's probably just white coat syndrome. It's probably nothing. And I said, okay. And then they never really asked me any other questions, and we would move on. And that was really it. And when it come down to is, I actually started keeping my own blood pressure at home, and I have consistently high blood pressure. So how can we know we have to go to a doctor and all of that, but how do we know, what are the questions we can ask a doctor to make sure that we have the right doctor to help us figure this out?
No, that's a great question. And your story with the blood pressure is something that makes my hair stand on edge. So normal blood pressure is less than 120/80, period. And there are then levels, mild hypertension, mild, or stage 2, which is more serious. So, and the truth is that, yes, I come in my white coat, and there really is such an entity of white coat hypertension. But as you followed up, that's not good enough to say, oh, it's just white coat hypertension, we'll see you next year. And the home monitoring that you talked about, I am a big fan of. The machines have gotten much more precise and luckily much less expensive. So I am a fan of home monitoring. You want to make sure that you check with your doctor that it's a machine. I use a company called Omron. I think it's $35 on Amazon or at Walmart. I have my patients the first couple of times bring that monitor in, so I know that it correlates. And then you can log at home. And then it's not just what goes on in the doctor's office, but it's trends. Is it, only in the morning I have it elevated? Are you drinking too much coffee before you wake up? So as I said, we customize the message. And high blood pressure, it's kind of like being a little pregnant. You either have it or you don't. And if you have it, you really want to treat it. With regard to your second question, what you want is a doctor who can become your partner for life. And there's no such thing as the best. You do want to get recommendations. So maybe if your gynecologist is someone who you really like and trust, ask your gynecologist who they trust for an internist, for a heart specialist. You do want it to be a doctor who understands you, who listens to you, who you feel comfortable and trust with, because ideally you want to be on that journey with them. You want them to hear your complaints, your concerns. You want to be felt that you're heard, not just told what to do, because that doesn't really work. And I joke, women will fire a hairdresser for one bad haircut. If you're with a doctor who's not listening to you, who you don't feel comfortable with, move on. There's lots of us around. And you also want somebody, frankly, for women who really understand women's health, because it's different.
And what's the difference, so if we start getting these regular physicals and testing and we find out, what's really the difference if I find this out that I have these markers when I'm in my 30s versus when I'm in my 40s, 50s, or 60s? What can I do? What can I do to change it? But also, what's going to be the real difference to me?
No, that's a fabulous question, because it speaks to the importance of starting early. So for somebody, as you shared with us, so if you were found at your age to have mild high blood pressure, if we begin the treatment appropriately decades before the 60s and 70s, when more women get events, we change the natural history of your likelihood. So this is like an equal sign. For every couple of degrees of blood pressure, millimeters, the points that you lower, there's an equivalent lowering in percentage of your risk of having a heart attack or stroke. So it's almost like, an equal sign. The same if cholesterol is found abnormally when you're young, if we manage it. The same with blood sugar or, inactivity. So you're almost getting a jump start on the long, runway for this disease.
And if I'm going to the doctor regularly and then I need to, at what point do I know that I need to escalate it to a cardiologist or my primary care, my internist is enough?
That's a great question. And it's interesting. There was some really cool data. She's actually a friend of mine who did the research. She's a cardiologist. She partnered with gynecologists, and they did this long-term research trial where the gynecologist asked 5 simple questions about heart health. And they found that those women did better, that they found things earlier, they referred. I'm of the opinion that, anytime you think that it might be time to trigger to a, more specialized level of care, you should be able to do that. I have plenty of patients who have great gynecologists and great internists, and maybe I see them once every year, every 3 years even. They may have minor risks, but they just want to be sure that they're getting in the right place so that if something changes, we already have a relationship.
When you talked about, going back earlier, so we talked about you see your physician and there are interventions the physician can give you, but when we were talking about nutrition and things like that, what can we do in our everyday life to make sure that we are being heart healthy?
No, absolutely. And part of my mission in life is for us to work together and figure out how to make it not so hard. And women, we're pretty hard on ourselves. If we're going to exercise, we're going to buy new clothes, we're going to join gyms. And the truth is, put on a pair of well-fitting sneakers and walk. And the same thing, with nutrition. I'm gonna finally eat right and lose 15 pounds this month. Then you don't, and you're disappointed. If you sort of think of it as small steps. So some of the things with food choices, we know what's good and bad. Fresh fruits and vegetables are really wonderful. White foods are not good, rices, white bread, any food that has, chemical names in the ingredients that you can't pronounce probably aren't good for you. And there's plenty of information online. We don't need fancy books or needing to see specialists about it. The American Heart Association, heart.org, has amazing nutrition advice. Our Katz website, has terrific nutrition advice. There are some people who do benefit from seeing a professional, a registered dietitian. But for many of us, it's just eating smart. And avoiding fad diets. Fad diets are okay if you need to lose weight to get into a party dress, but when we're talking about lifelong heart health, those things aren't usually so good.
Great, thank you so much. I know that the Katz Institute and everything that I see coming out of there is just it makes me feel confident that moving forward, that if I, do personally have these issues or other people that I know, that this research is being done and we are dedicating resources, not just monetary resources, but time and brains. Very smart people are working on this to try and help us figure this out going forward. I think we have a bunch of questions coming through in the chat. So I don't know if Elizabeth, you want to chime in with some of those, we can make sure people's questions get answered.
Yes. Thank you so much for that. That was really so informative and such critical information. And we do have a lot of questions. In fact, I received some questions even before today. So let me try and get to some of them. Diana wanted to know, what is the interaction that we need to understand between HDL and LDL cholesterol?
Okay, no, that's great. So thank you, Dana. And what Britt forgot when she was talking about that medical systems also rely on each of you to educate yourself and your family and come to us and demand from us, but also from our passionate volunteers like Britt and Nancy Burner and their law firm and the entire Katz Advisory Council, who are my new squad. So cholesterol, which you think of as the junk in the blood that can lay plaque on our bloodstream, comes in different types. It's a big fat molecule. Total cholesterol, you may see on your lab test, TC, is a number that is a math equation of all the other types. LDL is the bad cholesterol, and that's low density lipoprotein. And you remember it because you want it to be L, you want it to be low. And our bodies make cholesterol. Some of the foods impact on cholesterol. So that is a number we want to be low. For some people, they're naturally low. For others, they may require medication or different nutritional plans. The HDL, we want to be high. And what's interesting is that women on average have higher HDL cholesterols than men. We think that that's related to the estrogen when we're still getting our periods. And part of the risk that women get after menopause is that their HDL goes down. Interestingly, that the two are only connected in how they add up to what your total cholesterol is. And the other thing that's separate is that we have a lot of good drugs to lower LDL. We don't really have a lot of good ways to raise HDL yet. So, but that's a great question.
Thank you.
Following up on that, Dr. Rosen, so you're talking about the medications to lower LDL. Part of what I was learning about is that these drugs are not necessarily approved if women are trying to get pregnant or are pregnant. So can you talk a little bit about that?
No, Britt, thank you. That's a fabulous question. And it reminds me that part of my how do we become good patients and have good relationships is keeping your own records. So everything you put in your mouth, whether it's a prescription or a supplement, has to be on your drug list when you're seeing a doctor, because even the things that are non-prescription matter. And with regard to even planning on conceiving potentially, what medications you put in your mouth are critical. And we always talk about, ideally, if a woman could do preconception evaluations with a doctor, whether her gynecologist or her cardiologist or internist, to be sure that none of the medication she's on can even have a possibility of that. And the cholesterol drugs are one of them. Some other high blood pressure meds are in the no-no category. But some things in the past that used to be thought of, like antidepressants, which for some women are so important, can be safely continued. So no, thank you. That's a really important question.
Thank you.
Sorry, Elizabeth, one more thing on that. The other thing that I was reading about is about supplements you can take. And I think it's red rice yeast. Is that one of them? And I was actually told that, that is pretty strong medication. So can you talk about the use of supplements and how to properly monitor those?
Yeah, no, that is a huge, huge question, and something, honestly, we could get a bunch of experts together and do a whole session on together. So red rice yeast is actually similar to the component that is in statins, the classic drug, Lipitor, Zocor.
You said red rice yeast?
Okay. Yeast. And so for some people, small doses can be acceptable, but the challenge with many of the supplements and some of the other turmeric and coumarin products, or even some fish oils and things that we say, they are not regulated in the same way as your prescription drugs are. And you always want to be careful that the product you buy is safe, that it doesn't include additives that can be a problem. So there are actually websites that can help you navigate the safest and most regulated supplements. I have patients that sometimes come with a bag of stuff. I'm like, oh my God, that's a dinner out with your best friend. Put it in the garbage. So, but in some cases, there are some supplements. Red rice yeast can have some of the same side effects as statin without our ability to monitor. So only for the right people would I recommend that.
Right. So and bring them to your doctor.
If you're putting it in your mouth, yep, it all counts. Absolutely.
Great. In terms of advocating, we had a couple of people ask, are there certain heart tests that you should be requesting at your yearly exam?
No, that is a great idea. And again, like everything I'm saying, everything has to be customized to you. So there's no rule book that said at age 50, interestingly, right, at age 40, we all start getting our mammograms. And at age 50, we start getting our colonoscopies. There's nothing similar to that in the heart world for the more advanced testing. There's no such suggestion that, oh, you hit 50, you get a stress test, you hit 60, you get a this. What it is a customized approach based on your age, your risk factors, your concerns. There's a difference between me having zero symptoms of anything and going in for my checkup, and me going in for my annual and saying, it's harder for me to walk the steps. Maybe it hurts a little when I walk up the steps. And so that's a different thing. And what I actually like to teach our younger patients is, if you're only seeing your gynecologist as your, one good doctor, then the question should be, what do I have to know about my risk for heart disease? What do I have to do over the next 20 years to prevent it? And then get that discussion going. Well, you get a stress test at 40, you get something else at 45, so that it's really customized to you.
So making sure that you're having the conversation with your doctor and you're opening that door, asking those questions. Great. We had a question. Ainley wanted to know, what are the early symptoms of heart failure?
That's a great question. So if you imagine the heart, I'm sorry, I'm home, I don't have a model. So the heart is a pump. It's about as big as your fist. And it has arteries that feed it like everything else. And the heart's job is to pump blood to all the rest of your body. And heart failure happens when the heart muscle doesn't pump enough blood. And for some people, they can get it from having heart attacks. Some people get it from having high blood pressure that's undertreated for decades. Some people have infections that can cause it by causing heart valve damage. But at the end, if the heart can't pump well, you have heart failure. For some people, it can be shortness of breath, that they can't catch their breath when they're walking the steps. For some people, it could be swelling in their legs, what we call edema. For others, it can be a fatigue and just an inability to do your usual stuff. It can be a fullness in the belly that you feel too full when you eat even just a little bit of food. Those are the usuals. But the things that heart failure is like an end result of a lot of different conditions.
Got it. So those are some good things though for people to be aware of. We also had a question, Susan asked, does daily aspirin help women who are at risk?
That's such a good question. That is such a great question. So if we go back to, the 1990s when we did this, you'll laugh, it was called the Harvard Men's Study that came out, and it was all, Harvard doctor men, and that aspirin, a day. And we assumed, well, it worked for the Harvard doctor men, let's, do the women. And then Harvard did the Harvard Nurses Study, which was all women. And I kind of laughed because I had male nurse friends at Harvard and female doctor friends, but it showed that women were a yes also. But we've discovered, even just the last 2 years, some very important findings about aspirin. And this is just for people who don't have heart disease. So if you have known heart disease, if you've had stents or bypass, or you've had a heart attack, then the answer is different. And for you, if you have disease, aspirin is almost uniformly still recommended. But taking one a day, an aspirin a day keeps the doctor away, for most people is not recommended anymore. And I'm going to do my usual, but talk to your doctor. Everybody's different. But when my husband turned 40, he started getting his aspirin. When I turned 50, I started taking my aspirin. 10 years later, have stopped my aspirin. He has stopped his aspirin. So ask your doctor still, your clinician, your primary. But for most people, we've learned that the risk, intestinal bleeding and things like that, outweigh the benefit.
Thank you for that. That's good to know, because a lot of times people hear this information and so something very important. Joni wanted to know, what should you see a cardiologist? Should you see a cardiologist annually, or should it just be after you notice something?
Yeah, that's a great question. I think that depends. Again, back to you. I think a diabetic should probably see a cardiologist young, just to start the process. I think that, does everybody need to see a cardiologist? If you are feeling well, have minimal risk factors, and have a good primary care doctor, family medicine, internal medicine, GYN, it's not necessary for everyone. But I have to tell you, I kind of love the people who come to our practice who I only see every 3 to 5 years, because I know that, we've started that relationship, and they know that they have a team of us should something change. But it's not necessarily for everyone.
Okay, that's good to know. Eleanor has an important question. What options are available for women who don't have access to health insurance?
No, that's a marvelous question. Absolutely. And I think, for those of us, and that's part of the challenge, to be honest with you. So, what I know from all of the major health systems on Long Island are focused on community health. I mean, I've worked at Northwell forever, but I know the other health systems that are here, whether they're Manhattan-based with branches out here, are prioritize the communities function. So health. So I think, number one, the ability to get some coverage through the ACA still exists and hopefully will be strengthened. And much of what was originally in the Affordable Care Act was specifically aimed at women. And that's very important. Secondly, I think calling a health system's main number and asking what their opportunities are. In our cardiology department, we've got a clinic for our patient population that can't afford to be insured, and there are sliding scales starting at free for the care. So there are community-based resources that the Department of Health, both in Nassau, Suffolk, the 5 boroughs of Manhattan, can help with. It can be a little harder, but it's there.
So very important not to just think because you don't have insurance, there's no help for you, that you absolutely need to continue to advocate and find places where you can be seen, and that is readily available.
Yeah, and make sure that, in medicine, we weren't originally taught to think about costs. So, we'd write prescriptions. We didn't know how much they cost, and it's kind of crazy. But now there is much more transparency. You can find out, the $4 programs at Walgreens and CVS. The doctor could find a medication if you need one that's less expensive, that's easier to get. So, it's not making assumptions that, you're not eligible for things. Again, being an advocate.
Very important.
I would add to that just because you don't have health insurance in the traditional ways through an employer doesn't mean you're not eligible. So you should really look into whether you can qualify for certain Medicaid programs or other programs that are available through the state. And I would say going to the State Department of Health website is a great place to start for that. And that there are options out there that a lot of people aren't necessarily aware of in terms of health insurance. Very
important point to make to everybody. Elizabeth had a question. She said she was told that she has extra beats, quote. What does this mean? And can this be a problem? And can it cause fatigue?
No, that's a great question. So I told you that the heart is a muscle, but it also has blood vessels. The heart also has a battery pack, and we have an internal pacemaker that sends little electricity to the rest of the heart's wiring. And most of us have this electricity going in the same way all the time. But because there's other sort of electrical wiring in the rest of the heart, you can have a little electrical beat coming from a different place than usual. For most of us have extra beats. If we were wearing monitors all day long, we would all have these extra beats, premature beats, they're sometimes called. And most people never feel them. Some people do feel them. Sometimes they feel fluttering or palpitations. And it's important to know, again, individualized. There are some people for whom these are very dangerous. Maybe there's a family history of fainting or dying young of heart disease. Again, we go back to wanting to know all of that. For some people, these get so fast that they faint. And we certainly, you can't faint in front of a stove or when you're driving. But truthfully, for the most of us, these extra beats are completely benign. And it doesn't mean you ignore it. It means you tell your clinician about it. Some people may get some blood tests. Some people may get an echocardiogram, an ultrasound, or a stress test to determine that they're really benign or not dangerous. And then for some people, we can actually treat them. So it's a big, broad category of all the electrical things that can happen with your heart.
It's very important information for people to know that it's so specialized, that per person, so that it's not about searching the internet or asking a general question, but that these are all questions that you should address with your primary care and cardiologist, and make sure that they're looking at, a whole host of past and your family history. But speaking about that, Sherry was asking, if someone is adopted and they have no access to family health history, how should a doctor and how should a person approach their heart health care?
No, that's a great question. That's something that I've dealt with in my practice, and it is very important. Depending on the other risk factors, the ones I can judge at the time, I can tell if they have high blood pressure, if their cholesterol is abnormal. Depending on how risky those are, I will always assume the worst. So if they are somebody who has pre-diabetes, I may say to myself, well, let's assume that their family history was also bad for heart disease, and maybe I'll test more aggressively. And there are some people in the past who've been so anxious about that I've done some more aggressive testing just to put them at ease about not knowing their family history. It's an interesting question.
Yeah, it is.
Is there genetic testing that can be done as an adult to find out some of these things if you don't know who the people are in your family?
That is such a great question, Britt. So there are some hereditary diseases that can be tested for, but because they're very unusual, we don't uniformly test them. Some weird fainting spell diseases, but they are looking at the genetics of the traditional, atherosclerotic heart disease, the plaque in the blood vessels, to see if there are some genes that ultimately we could test everyone for. So there's a lot of really cool research going on in just that right now. It's a great question.
This is incredible. I mean, we could be here all afternoon asking questions, because you're so easy to talk to, Dr. Rosen, and you've given us so many wonderful, wonderful questions, but I do want to respect everybody's time and thank you so much, both of you, Britt for bringing this, and for Burner Law Group for sponsoring such a very important topic. And thank you, Dr. Rosen, for your expertise. I wanted to let everybody know that you are officially being welcomed to the Katz Circle, to the Katz Women's Circle, and you'll have a free membership that will be for all supporters of the Katz Institute. And you're going to be able to join this vibrant community of women's health advocates and champions, and you'll be a key part in their efforts to help improve healthcare outcomes for all women. So you're going to receive a newsletter offering an inside look at their efforts, along with the critical conversations that they're bringing to light. They'll be easy to share content that simplify the process of passing along the message to the women that matter most in our lives. And there'll be opportunities to share your own healthcare story. So the Katz Women's Institute Women's Health is also on social media. You can follow them on Twitter as well as on Facebook. At Twitter, they're at Katz Women's HLTH. We're going to also provide this information via email to you so that you'll have that in your inbox too. You don't have to worry about writing everything down that I said. And so you'll be able to get all of this information. So thank you so much, everyone, the attendees, fabulous questions. Thank you for being a part of this. Again, thank you, Britt Burner, Dr. Stacey Rosen, and I want to wish you all to stay healthy, stay safe, and don't forget about your heart health.
Great. Thank you so much.
Have a great afternoon.
Thank you.
Bye-bye.